talk a little bit about a subject that's kind of near and dear to my heart called chemoprevention of Lynch syndrome. And I think that's something that, you know, it's kind of a scary word. So first, I'd just like to talk a little bit about what the objectives are for this talk. I'd like to define what chemoprevention actually is and talk about what recommendations are for chemoprevention for patients who have Lynch syndrome. And then talk a little bit about how you make decisions regarding whether or not to take a chemopreventive agent, in this case, a medication. So chemoprevention is really the use of medications to prevent or slow the development of cancer. A lot of people get very nervous about that word because it's got chemo in it. It makes them think of chemotherapy like you would use for a treatment of an advanced cancer, but this is really not chemotherapy in the usual sense of the word. The kind of medicines that we think about for chemoprevention, because it's in a setting that someone does not have cancer already, they tend to be medicines that have a lower risk of side effects, and again, that are not necessarily used in the treatment of cancers. Sometimes we call this therapeutic prevention, and of course this is a very hot area of investigation, particularly for people who are at inherited risk of cancer. You heard me in the first presentation mention the NCCN, or the National Comprehensive Cancer Network, and they do have guidelines for whether or not chemoprevention should be considered for a couple of different kinds of cancers, and they do break it down by the specific gene type. So here we see a clip from the NCCN guidelines that suggests that use of aspirin, 600 milligrams per day for at least 2 years, can decrease the risk of colorectal cancer in patients who have Lynch syndrome. So we're going to talk a little bit more about that. It's important to know that they reiterate this recommendation in the MLH1 guidelines, the MSH2 guidelines, and the MSH6 guidelines. They do say that the benefit is unproven in PMS2, and I'll talk more about that in a minute. So really, where does this recommendation come from? It comes from a study called CAPP2, CAPP2, which was conducted a few years back in the United Kingdom and elsewhere. And this is a very large study that was entirely Lynch syndrome patients. Now, at the time, they were defined by having an inherited mutation in MLH1, MSH2, or MSH6, or having a family history consistent with Lynch syndrome due to family history criteria that we used before we knew how to test efficiently for these kind of genetic mutations. So they were able to get a very large group of Lynch syndrome patients, which I think kind of underlines two things. First of all, that these kind of studies can be performed in high risk, but also it kind of underlines how common Lynch syndrome really is when you look at that. So it's important to think about that as well. You know, some sources say that Lynch syndrome is present in as many as 1 out of every 280 individuals. And if those figures are accurate, then it's actually more common than BRCA1 or BRCA2 mutations, which we hear a lot more about in the media. In any case, going back to the study, the patients were randomly assigned to taking 600 milligrams of aspirin a day, or a placebo that looked like the aspirin. And they were what we call blinded, meaning that they did not know if they were on the aspirin or if they were on the placebo. Neither did the doctors that were treating them. This was controlled through the study mechanism that they were given these blinded medications to take over the course of quite some time. And they were followed for about 4.5 years, and then assessed for whether or not they had developed colon cancer or other cancers associated with Lynch syndrome. The results, the strongest result that we found from this was that patients who took aspirin for at least 2 years on a daily basis had about a 59% reduction in colon cancer risk. There was also what we call a non-significant reduction, meaning that the statistics were not as definitive for reduction in non-colon cancer, non-colon Lynch syndrome cancers as well, such as uterine cancer and ovarian cancer. And again, these are all kind of grouped together because the major objective here was to look at colon cancer risk. So based on this study result, a group called NICE, which again is a British group, made what we call a patient decision tool to kind of give this information, make it a little bit more patient accessible, and help Lynch syndrome patients work with their healthcare providers to make decisions about whether using aspirin to reduce their colon cancer risk is right for them. Now, I do have the link listed here, but it probably would be easier just to say, just Google something like Lynch syndrome, should I take aspirin, or Lynch syndrome aspirin patient, or something like that, to try to get to the same place. But it is at nice.org.uk. And so they have some very nice graphics here to help us kind of understand what happened in the two groups and the impact of the aspirin amongst the groups. So you can see here that this is the group in the study that took the placebo and did not take aspirin on a daily basis. And we see here that after following them, we can see that out of every 100 patients in that group, 13, again, these are Lynch patients with Lynch syndrome, 13 out of that 100 got bowel cancer in the course of 10 years. So that's a couple things to realize. I mean, you know, in the general population, we would expect probably about maybe five of those people out of the 100 to get bowel cancer in 10 years. So this is higher than average, but again, it's also important to realize that having Lynch syndrome does not necessarily mean that you're destined to have colon cancer, and that there are some people who aren't going to develop colon cancer. So even in the people who did not take aspirin, the overwhelming majority of them did not develop colon cancer in the 10-year period. The other thing, of course, is that your life expectancy is going to be more than 10 years, so we do have to keep that in mind as well. This next slide looks at the people who took aspirin on a daily basis for at least 2 years. And again, this is a 600 milligram dose, which is a pretty high dose of aspirin, okay? So on average, for every 100 people who took aspirin for at least 2 years, 7 people did get colon cancer, but 93 of them did not. And again, we're comparing that to the 13 who got that in the non-aspirin arm. So we can see here that the difference of the aspirin is really the difference between the 13 who got the colon cancer in the non-aspirin group and the 7 that did. So 6 people did not get colon cancer because they took aspirin. 87 people did not get colon cancer, but again, they wouldn't have gotten colon cancer if they took aspirin or not, you know, based on, again, the statistics. And again, we're generalizing based on the population here. This isn't something that we can point to a specific individual and say, this is going to be effective for you and this is not going to be effective for you. The other thing that's important to realize is that 7 people still did get colon cancer, even though they took aspirin on a regular basis for the 2 years. So we can see the impact of the aspirin, but we have to realize that for some people, there is going to be some risk associated with taking aspirin that wouldn't have necessarily gotten colon cancer regardless. And for some people, they will get colon cancer regardless of taking the aspirin or not. So that can be kind of something that can be a little bit hard to wrap your head around sometimes. But I think that this is an illustration that does point out the difference and make the study a little bit more digestible for the general population as well. So I'd like to talk for a minute about the risks of aspirin use. And we don't really generally think of aspirin as a particularly risky drug. It is over the counter and you know, very commonly used. But we do have to keep in mind that when it's taken regularly, there can be some increased risk of bleeding or bruising. And that generally occurs in about 1 to 10 out of every 100 people who take it. So again, it is a real risk. It doesn't happen to everyone, but it is something that we do have to consider. And certainly if someone had a bleeding problem or bruising problem prior to that, then aspirin may not be a very good choice for them. We also do know that aspirin can increase the risk of stomach ulcers and small intestine ulcers as well. Those, again, are things that generally can be treated, but then thinking about things that can be really big problems, there is a chance of having a major bleeding event in the gastrointestinal tract with aspirin. However, that risk is pretty small. It's about 1 to 10 people out of every 10,000 people would have an event like that. So that risk is real, but it is, again, a pretty small risk. Still, 9,999 would not have that risk. It's also important to know that of those people who did have a stroke, that can sometimes worsen the outcome of stroke if it is in fact due to a bleeding. There are two different kinds of strokes. The most common kind of stroke is due to a blood clot going to the brain, but a less common type of stroke is due to bleeding in the brain. And if it was the less common stroke that's due to bleeding in the brain, then that, of course, could be worse if the blood is thinned with the aspirin use. Other things that we have to think about when we think about whether or not to take aspirin for chemoprevention is that the dose and duration of use is not known. 600 milligrams of aspirin per day, as I mentioned before, is a pretty high dose of aspirin. Is it possible that you could still get the benefits and not have as much risk if you took a lower dose? Certainly that is possible, and there are studies that are ongoing right now to address that. The other question is, how long would you have to take the aspirin on a daily basis to have that benefit? And we know that some of that benefit extends well after the time that you actually took the aspirin. So if you took aspirin for 2 years, you could have benefit for years after that potentially. We also have to think about who's more likely to have side effects from the aspirin, and we do know that older patients are more likely to have side effects. If you think about it, that makes sense as in terms of bleeding and bruising. Older patients do tend to have more fragile skin and do tend to have an increased tendency to bleed. Of course, when we think about stroke and things like that, strokes are, of course, more common in the older population. We also don't recommend aspirin to be used in the later stages of pregnancy or when someone is breastfeeding. But overall, we have to keep in mind that although we don't have a crystal ball, we can predict some things on a population basis and on a statistical basis. But for the person that's sitting in front of us, we can't always say this is what's going to happen to you. Changing gears a little bit to think about chemoprevention for gynecologic cancers. And I think that this has already really been discussed previously, and I'll add a little bit, but there's not a lot of data, unfortunately, in this situation. So our NCCN guidelines say consider risk reduction agents for endometrial and ovarian cancers, and they basically have the same recommendation for all of the different gene mutations. What they generally are referring to this is oral contraceptives, and as Dr. Mara referred to before, estrogen and progesterone oral contraceptives can decrease the risk of endometrial and ovarian cancers, whereas progestin only decrease the risk of endometrial cancers. Again, this is based on studies that were done in the general population. There are no placebo-controlled trials that I know of at this point in time that are specific to the Lynch syndrome population. So we're extrapolating data from what we know about what oral contraceptives can do in the general population. Some doctors have been looking at whether the thickness of the uterine lining and what we call endometrial proliferation or growth in the uterus can be altered by taking oral contraceptives or Depo-Provera, and they have seen some encouraging results there. But again, that is something that does require more specific study in the Lynch population as well. And as Dr. Mara alluded to, what we know about risk reduction for oral contraceptives and ovarian cancer is primarily really based on a different hereditary cancer group, those who have mutations in BRCA1 or BRCA2. When we look at those groups, we see that using oral contraceptives causes about a 50% risk reduction with risk reduction for ovarian cancer. But again, specific studies for Lynch syndrome are lacking at this point in time. So having said all of that, still because of the lack of specific data in Lynch syndrome, as well as the issues regarding screening for gynecologic cancers for Lynch syndrome, oftentimes surgical options, as Dr. Mara discussed earlier, is one of the mainstays of management of these gynecologic risks for people who have Lynch syndrome. So again, this is an area where a lot of research is going on. I alluded to the study looking at different doses of aspirin and cancer risk for colon cancer risk for Lynch syndrome patients. The first study was called CAPP2. This one is called CAPP3, not surprisingly. They have gotten their study together. They've gotten all of the patients that they need to participate, and they're now in a data collection mode and starting to learn more about that. Here at Huntsman, we have recently participated in and published with Dr. Kant a study looking at what we call biomarkers based on Lynch syndrome patients taking an anti-inflammatory drug called naproxen. And that has some very promising preliminary results, but again, it is at a very early stage and is not really ready for what we call prime time right now. Certainly additional study will be required, but these preliminary results have been very encouraging. Other areas of investigation are looking at omega-3 fatty acids to help reduce colon cancer risk in Lynch syndrome patient, and also, just as I mentioned about immunotherapy for treatment of cancers, we are starting to look at immune approaches for prevention of cancers as well, including both vaccines and some of the drugs that we think about using for cancer treatment. These are all very exciting areas of investigation, but again, are not something that we really would consider ready for prime time outside of a study at this point in time. So with that, I'd like to close this presentation. And again, thank you for your attention. I'll be happy to address any questions.